So why do we do such a bad job providing adequate nutrition in the ICU? Why is the U.S. dead last in nourishing our critically ill patients?
And I think some of that goes back to what we mentioned before, right? 75% of U.S. medical schools don't teach any clinical nutrition. It is taught better in other countries. I think we like to focus on things we can measure. And I've said this for many years, and I think we are finally starting to personalize nutrition like we're personalizing other care, right? We wouldn't give a vasopressor without measuring a blood pressure with an A-line or even a cuff. We wouldn't have somebody on a ventilator without a SAT probe and a blood gas. And so I think the lack of data for both prescription and for outcome sorts of things has really limited us. Now, it was neat. I got to work with a group in Europe as part of a grant the European Nutrition Society gave us to work with industry to build a better metabolic cart. There is a new metabolic cart that measures very accurately in 5 minutes. You don't need a respiratory therapist to do it. You don't need to calibrate it for an hour. It measures in 10 minutes and gives you very robustly accurate energy expenditures. And we're using that more and more in research and clinical practice. And we're realizing the targets that our equations predict are right less than the flip of a coin of times. They're about a third times they're right. A third of the time they overfeed, which we know is bad and causes infections, and they're a third of the time low and cause mortality and complications.